This is a short video on preventative care. I'll be talking about vaccines in both adults and children, as well as screening for medical disorders, for psychosocial disorders, for substance abuse, for infectious diseases, and for the 4 main types of cancer that we screen for. This is everything that's going to be in this presentation. I'm going to clear it all and show it one by one, so if you want, take a screen cap, and if you want to hear me talk about it, keep listening. So first we have these medical diseases that we screen for. The first 3 are all cardiovascular risk factors, and they're all kind of related to each other. First is hypertension. We screen all patients for hypertension, usually at every clinic visit. So this is pretty easy to slap on the blood pressure cuff and to check their blood pressure. In order to make the diagnosis of hypertension, you do need 2 tests, 2 blood pressure readings, and they need to be 2 weeks apart. So one screen is not enough to diagnose hypertension, but it's something that you do at every visit. Next is hyperlipidemia. This is typically done as a blood test, a lipid panel. It'll give you the LDL cholesterol, the HDL cholesterol, as well as the total cholesterol and the triglycerides. We do this typically annually, starting in men at age 35 and in women at age 45. Any patient that has cardiovascular disease or cardiovascular risk factors, such as hypertension or diabetes, will get this screen starting at 20 years old, and that includes problems with their aorta, like stenosis, as well as problems with their peripheral vasculature, their coronary vasculature, and their carotids. All those people will get lipid panels. So it's really quite a bit. It's almost all patients get an annual lipid panel. Next is diabetes. We screen for diabetes in people that are obese, in people that have hypertension, and in people that have hyperlipidemia. So again, these 3 are all very related. The main test that we do for diabetes screening is the hemoglobin H1C. This will give you an average hemoglobin from an average blood sugar from the past 3 or 4 months. But there are other tests for diabetes. You could do a fasting glucose, a random glucose, a 2-hour glucose tolerance test, but really the easiest is the A1C because it gives you an average. These other tests, like the random glucose and the 2-hour glucose tolerance test, you might need 2 readings of those on separate visits, so the A1C is really easier in that regard. We also screen for AAAs, the abdominal aortic aneurysm. This is an ultrasound. It's usually a one-time screen done in men who are 65 to 75 who have ever smoked. So even if they've been a smoker and they quit many years ago, you would still do this screen for abdominal aortic aneurysm. Now, if these men have a normal ultrasound, you don't need to do it again within this time frame. It's only a one-time screen. And if they've had other types of imaging, for instance, if they had a CT of the abdomen for another medical problem, and that CT showed no aneurysm or no signs of problems with the aorta, you don't need to do this ultrasound screen. So other kinds of imaging can take the place of the ultrasound, but if you have no other imaging, you do the ultrasound one time in this age range. In women, starting at 65, so this is kind of the female version of the AAA, you screen for osteoporosis. This is done with a DEXA scan, and again, it's a one-time scan if it's normal. If the patient is found to have osteoporosis, you would want to repeat this annually to kind of track the progression of the disease. So one-time scan for women is osteoporosis, starting at 65. One-time scan for male smokers is the ultrasound for abdominal aortic aneurysm. Next, we have these psych-social problems that you screen for. We firstly screen for depression. There's several different kinds of screens for depression. The shortest and the quickest is the PH2Q, which is essentially just 2 questions. It asks you, have you felt down, depressed, or I believe guilty or hopeless? And the second question is, have you lost interest in things that you previously enjoyed? And it has you kind of rank how frequently you would answer yes to those questions. And if that comes out positive, it indicates the patient might be depressed or might have signs of depression, and you can then proceed to a longer questionnaire like the PHQ-9 or the EDPS or the GAD-7. The GAD-7 is actually for anxiety. That's generalized anxiety disorder, but we often think of anxiety and depression as kind of coexisting, so screening for one kind of leads to a screen for the other. So this is the short one. These are the longer ones. These are often done at annual visits for adults and for kids older than maybe 12 or 13. We also screen for intimate partner violence. Now, a quick, easy way to do this is to simply ask their patient, do they feel safe at home? So when you're taking a social history, you ask about their work, you ask about their life, You ask about who they live with at home, and if they have an intimate partner, it's very easy to just ask, do you feel safe? That's your screen. You can do that annually. We also keep an eye out for abuse in vulnerable populations. This includes children, in disabled people, and in elders. We can make another video about this, but there are several signs of abuse in children, such as injuries in kind of random locations throughout the body. There's a characteristic dunk burn for a child that's been dipped in a hot bath. That's worth looking up to see what that looks like. Children that tend to run toward the medical provider or cry a lot when near their caretaker during the visit is suspicious for abuse as well. Abuse in elders is sometimes a little more tricky. Think of an elderly person that has been able to afford their medications for many years, but then all of a sudden cannot. You might suspect that somebody is squandering that elderly person's money. Or if an elderly person who walks very well and doesn't have dizziness or lightheadedness is claiming to have injuries from falls, that might be a sign of abuse from somebody living with that elderly person. So that's worth keeping an eye out for as well. Next is screening for substance abuse. We have smoking and alcohol here. For smoking, it's a lot of asking at annual visits. So you ask the patient about their tobacco use, you advise them to stop smoking, and of course you provide behavioral interventions and pharmacotherapy to help them stop smoking. For alcoholism, we typically do the CAGE criteria. This is a series of 4 questions that help you see if a person might have an alcohol use disorder. The first question is whether this person feels like they should cut down on alcohol. Second is, do they get angry when other people comment on their alcohol consumption? Third is, do they ever feel guilty when drinking? And the fourth is, do they ever feel like they need an eye opener or a drink first thing in the morning? So if you respond to if you respond yes to any of those questions, that might indicate an alcohol use disorder, and that might prompt further evaluation. There's these infectious disease screens next. We screen for HIV with one ELISA test in anybody aged 15 to 65. You do want to confirm that this ELISA is positive before reporting it to the patient. So typically it's an ELISA, and then you could do a follow-up test with better specificity to make sure they have HIV before you have that talk with the patient. HIV screening is pretty easy. You can repeat it in high-risk patients, such as patients that are sexually active or that have multiple partners or IV drug users. So you can do that pretty regularly if need be. Hepatitis C is an antibody test, and this is typically done in the baby boomer generation. That's people that were born between 1945 and 1965. We also do screens for chlamydia and gonorrhea. This is typically in sexually active women that are less than 25 years old. These diseases can be asymptomatic in women, and it can lead to problems like pelvic inflammatory disease down the line. So it's a pretty easy screen in sexually active women to help prevent that. Next, I'll be talking about these cancer screens. Now, there's 4 main cancers that we screen for. There's lung, colon, cervical, and breast cancer. Let's start with lung cancer. We do an annual low-dose CT scan in patients with a 30-pack-year smoking history between the ages of 55 and 80. Now, this is a low-dose CT scan because you're doing it every year. You don't want to blast them with radiation every time. We do it in people that are fairly heavy smokers, so 30-pack years could mean that you smoked 1 pack a day for 30 years, or maybe you smoked 3 packs a day for 10 years. If the patient has quit, but it hasn't been 15 years since they quit, we still do this screen. If the patient has quit more than 50 years ago, then we no longer screen them for lung cancer. So again, that's a low-dose CT scan, not an X-ray, in smokers with a 30-pack year history between the ages of 55 and 80. Colon cancer screening is a little more complicated. They recently changed the age. It used to be 50 or 55. Now it starts at 45. It goes until 75. There's decent evidence for it going until 85, especially in people that are high risk. You would want to start colon cancer screening earlier if that person has a first-degree relative who had a diagnosis of colon cancer. So for instance, if a person's father was diagnosed with colon cancer at age 40 or 45, you would want to screen them 10 years before their father's diagnosis. So you'd want to screen that patient starting at 30 or 35. Now, the screening options are pretty varied for colon cancer. You can do a colonoscopy every 10 years. The reasoning for this is that a polyp that you might find on colonoscopy typically takes about 10 years to develop into cancer. So if you can find that polyp early, you can remove it, and you can do a colonoscopy once every 10 years. That's the least frequent screening that you can do for colon cancer. Another option is a flexible sigmoidoscopy, and you would do this every 5 years. This is similar to a colonoscopy in that you're putting a camera and looking up their bottom. This is done more frequently because it doesn't go quite as far up into the colon, so it kind of looks into the sigmoid colon. Another option that's relatively new is Cologuard. This is the brand name. It's really stool DNA, so they'll send a stool sample in, and that stool sample is analyzed for signs of for DNA that might indicate colon cancer. This is something you would do every 3 years, and it's worth checking to see if the patient's insurance covers Cologuard before you send that. Then the most frequent option is the fecal immunochemical test, the FIT test. It's pretty similar to the guac fecal occult blood test. This is something that you would do annually, but it checks for blood in the stool. Blood in the stool, oftentimes occult blood in the stool, is a sign of colon cancer. So that's that screen. So several options for colon cancer. Next is cervical cancer in women. The age range for this is 21 years old to 65 years old. So you start with a pap smear every 3 years, starting at age 21. Now, if you have a sexually promiscuous woman that's less than 21 years old, you still start at age 21. So don't be deceived by a situation where somebody is high risk for HPV, but they're younger than 21. You only start pap smears at age 21. The reason for that is that those patients might have HPV, but their body is able to clear it before the development of cervical cancer. Another option for patients that are over 30 is to get a pap smear and an HPV every 5 years. So that'll let you do the pap smear a little less frequently, as long as you get the high-risk HPV testing as well. So cervical cancer, age 21 to 65, every 3 years. Lastly, of the major cancer screenings we have is breast cancer. Now, there are several groups, agencies, professional societies that have different recommendations for this. There's the USPSTF, there's the American Cancer Society, there's this should be ACOG, American College of OB/GYN. They all have different numbers. So typically it's a mammogram every 1 to 2 years, starting at age 40 to 50. I've kind of underlined 2 and 50, so that might be something you can remember. So starting at age 50, do a mammogram every 2 years. We used to promote doing breast self-exams. There hasn't been good evidence that shows that that's a good way to catch breast cancer early. There are a lot of false positives. It leads to a lot of further workup that doesn't necessarily improve the mortality in patients. So we don't really promote that anymore. You can stop doing breast exams at age 75 unless the patient is high risk. So of course, unless they've had breast cancer in the past. So for breast cancer, just think of starting at age 50, every 2-year mammogram, stopping at age 75. Prostate cancer is one that we used to screen for and stopped kind of recently. So you still want to screen for prostate cancer in high-risk individuals. This is people that have a family history of prostate cancer, specifically of a family member who died of prostate cancer or somebody who has urinary symptoms. Perhaps we used to do the digital rectal exam as well as a PSA blood test. The PSA does detect lesions, but they most often don't need to be treated. The saying that a lot of people say about prostate cancer is that men die with prostate cancer, not of prostate cancer. So oftentimes people get prostate cancer and their cause of death is something completely unrelated. So there's little reason to screen for prostate cancer, make the diagnosis, have a bunch of biopsies done, have a bunch of treatments if it's not going to harm these patients anyway. We also no longer screen for ovarian cancer. Endometrial cancer, there's no screen unless the patient has symptoms such as postmenopausal bleeding. And there was a lot of research done into these tumor markers like the AFP, the CEA, and the CA125. These are tumor markers of some kinds of cancers, but they're not very specific. They're not very sensitive. In general, we don't use those for screening. You might use those on oncology just to kind of track the progression of a cancer, but it's not for screening. It's not for everyone. Lastly, let's talk about this vaccination column. Now, this is vaccines in both adults and children. Start with hepatitis B. Hepatitis B is a vaccine given to all children. There are 3 doses. You give the first dose at birth, so that's at the hospital before the kid goes home. You give the second dose between 1 and 2 months, and the third dose between 6 and 18 months. In adults, you especially want to make sure they've been vaccinated for Hep B as a kid. If they haven't, and if they work in healthcare, if they have end-stage renal disease or diabetes, if they're IV drug users, or if they have liver disease, you want to make sure they're vaccinated for Hep B. Next is Haemophilus influenza type B. You give this to all children, and there are 4 doses. The doses are given at 2, 4, and 6 months, and the last dose is given at 12 to 15 months. Next is the combination vaccine for tetanus, diphtheria, and pertussis. All children get this in the form of the DTaP vaccine. This is different from the Tdap that the adults get, but all children get 5 doses of DTaP. They get them at 2, 4, and 6 months, and the 4th dose is between 15 and 18 months, and the 5th dose is between 4 and 6 years. Adults need to get a booster for tetanus, diphtheria, and pertussis every 10 years, and it's also worth knowing what to do for tetanus if somebody comes in with a wound. So if a patient comes in with a wound that is, and that patient is not sufficiently vaxxed, which means they've had less than 3 lifetime doses of tetanus vaccine, you want to give them the tetanus immunoglobulin. This is a medicine that's made up of antibodies from a bunch of blood donors, and those antibodies are against tetanus, so that'll help their body fight off a potential tetanus infection. If the person comes in with a wound that is dirty, a dirty wound is something that like breaks skin, that they got on rust or another person's fingernail, something from metal, or something, just generally a dirty wound, and their last vaccine was more than 5 years ago, you want to give them a booster shot that day. You want to give them a Tdap that day. If the wound is clean, like it doesn't really break much more than the skin and it was on a relatively clean surface, they can be fine without a Tdap booster unless their last vaccine was more than 10 years ago. So that's kind of your threshold for giving a booster shot for somebody that comes in with a wound. If it's a clean wound, last vaccine was more than 10 years ago, you want to give a booster. If it's a dirty wound, last vaccine more than 5 years ago, give a booster. And if the person hasn't been sufficiently vaxxed, you want to give a booster as well as this tetanus immunoglobulin. Polio has a vaccine. Kids get 4 doses of IPV, which is the vaccine. Those 4 doses are 2, 4, 6 months, and the 4th dose is between 4 and 6 years of age. Meningococcal is the next one that we vaccinate for. All kids get meningitis A and meningitis B vaccines. You get meningitis A at age 11 or 12, and then again at age 16, and you get meningitis B at age 16. Adults can also be vaccinated for meningococcal, and that specifically is done in adults that don't have a spleen, in people that are going to live in a college dorm, in military barracks, in people that are making a pilgrimage, such as Islamic people go into Mecca, and in patients with HIV. So those would be high risk for meningococcus. The pneumococcal vaccine is given to all kids. There are 4 doses of the PCV13 vaccine. That happens at 2, 4, 6 months, and the last dose is between 12 and 15 months. All adults over the age of 65 also get this PCV13 vaccine, and they also get a second one called PPSV23. And you normally want a 12-month gap between these 2 pneumococcal vaccines in adults. You don't need to worry about this gap if the patient is immunocompromised, if they're asplenic, if they have cochlear implants, and if they have a CSF leak. So normally in adults, you give it with a 1-year gap unless they are particularly at high risk for pneumococcus. Influenza's next. That's the flu vaccine. Kids can get this starting at age 6 months, and it's something that you give every year for kids and adults. You especially want to give it to people that are immunocompromised, that work in healthcare, or women that are pregnant. This is contraindicated only if somebody has an anaphylactic reaction to eggs. Now, if their reaction to eggs is just a rash, that's okay. You can give them the vaccine and watch them for 30 minutes, make sure they don't have a worse reaction. If a patient is immunocompromised, or if they have a contraindication to influenza, if they have an anaphylactic reaction, you can also give them the recombinant variant of the flu vaccine. That works for people that are at least 18 years of age. There's an intranasal variant of the influenza vaccine. Normally it's done intramuscular, but some people want it up the nose. It's a little easier. That's a live vaccine. You don't want to give that in immunocompromised people. Next is hepatitis A. This is done in all children between the ages of 12 and 24 months. Adults can get this as well. You might want to think about it if you're traveling to an area endemic with Hep A. IV drug users and people with liver disease might also get the Hep A vaccine. Next is the varicella zoster series. All children get this. This happens between 12 and 15 months, and again between 4 and 6 years. Before this vaccine, people would have pox parties where one kid with chickenpox would be brought into a party with a bunch of other kids that hadn't had chickenpox yet, and that would be their way of spreading the virus and kind of getting it over with. We don't do that anymore now that we have the vaccine, so endorse people getting the vaccine instead of going to a pox party. In adults, starting at age 50-ish, you can give Zostavax. That's a zoster vaccine, and that'll help them prevent getting reactivation of the varicella that can lead to pain, a rash, and a dermatomal distribution, and post-herpetic neuralgia. Now, these are also live vaccines, so you don't want to use them in immunocompromised people. Next is the MMR, or the measles, mumps, rubella vaccines. All kids get this. There's a dose between 12 and 15 months, and there's a dose between 4 and 6 years. This is another live vaccine, so you don't want to use it in immunocompromised patients, and you don't want to use it in pregnancy. There are a few side effects to be aware of here. So it can give you a little fever, and that fever in kids can lead to seizures. It's not uncommon for kids to have seizures when they spike a fever. It can also cause muscle pains and a bit of a rash, but those are typically short-lived. Rotavirus is another vaccine. Kids can get 3 doses of this, also at 2, 4, and 6 months. This is another live vaccine, so you don't want to use it in immunocompromised people. The main side effect here is intussusception, or telescoping of the bowel. So if a kid has a history of that, you don't give them the rotavirus vaccine. Lastly is human papillomavirus. This is HPV. This is the virus that can infect the cervix and cause cancer, so this vaccine is pretty important. All children get 2 shots of HPV if they're between the ages of 11 and 12. They get 3 shots if they're over 15 years of age or if they have a weak immune system. One side effect of HPV vaccine is syncope, so take a look and monitor the kids for 15 minutes before they get that. It's worth noting that both boys and girls get the HPV vaccine. So women are the ones that would get cervical cancer, but we also give it to boys to prevent them from spreading HPV, also to prevent the women from getting cervical cancer. So both boys and girls get HPV. That's it for preventative care. That's it for screening and vaccines. I hope it was helpful, and thank you for listening.